I'm Dr. Nimit Shah, consultant interventional cardiologist. Having been trained in UK as a cardiologist for 13 years, I came back to India in 2014. My practice is based in South Mumbai and I'm attached to Safi Hospital, Bridge Candy Hospital, H&N Reliance Hospital, Wokhart Hospital and Jasrok Hospital. You are right, heart attack is the leading cause of death in India, in fact all over the world. And it is exponentially increasing because of the various risk factors, changes in the lifestyle, and in India, more prevalence of diabetes as well. There are 3 treatments available for the heart attack. One is thrombolysis, which is a medical treatment. Second is angioplasty, like deploying a stent. And third is a bypass operation. Coronary angioplasty is an invasive way of treating the blocked artery. So what we normally do, we do this procedure under local anesthesia. This is either done through the wrist or through the groin without putting patient at sleep or without any cuts. So what we do is we puncture the artery in the wrist or the groin, then pass a tube down your artery which goes into the heart. Then we inject the dye and see how the dye is flowing within that artery and find out any blockage. That is angiography. Once we identify the blockage and we go ahead with the treatment. So through the same tube, the wire is passed through that tube into the artery, then a balloon is passed over the wire. We place the balloon where the blockage is, we inflate the balloon and open up the blockage. The balloon is removed and then the stent, which is like a metal meshwork, like a spring, which is mounted on the balloon, which is passed over the same wire where the blockage is. We inflate the balloon so the stent, like a metal spring, expands and hugs to the wall of the artery. The balloon is deflated and the balloon is taken out and the metal spring or the stent stays there to keep the artery open. That is angioplasty. It's a very important question which I need to answer. Not every blockage requires a stent. It all depends how the patient has presented. For example, if the patient has presented with a heart attack, that angioplasty becomes a life-saving procedure. If there's a significant blockage, mostly during the heart attack, the artery is 100% blocked. You need to open up as soon as possible. So that's a life-saving procedure. But if the patient has not presented with a heart attack and is just presented with angina, what is chest pain when he exerts himself, and when we do an angiography and we find there's a significant blockage, then apart from medical treatment, which remains the main treatment even after putting a stent in, we would advise angioplasty. But there are other subset of patients who do not have much symptoms. For example, they have gone for the health checkup, and during the health checkup, the stress might be slightly positive. They either go to CT coronary angiography or directly come for angiography because they are concerned because of strong family history and risk factors, and we find there might be around 60, 70 or 80% blockage. If the patient doesn't have any symptoms, there's no mandate in putting a stent or doing a bypass operation. In fact, the research and the evidence says the medical treatment is as good as putting a stenting or doing a bypass operation. Unless we do another test, which are known as a ischemia test. For example, we do a dobutamine stress echo or we do a nuclear scan, and we find when we put the heart at stress, there's significantly decrease in the blood supply to the heart muscle. Then we can consider doing an angioplasty or bypass operation. But if the patient doesn't have symptoms, he can walk, climb 2 stairs without any symptoms. Even if they have a blockage, they can be safely managed with medicines. There's a bare metal stent, which is just a simple metal spring, and there's a drug-eluting stent, whether the drug coated on that metal, which is gradually slowly released within the vessel artery. And there's a third type of stent which was made available, which has now been taken up, which is a bioabsorbable stent, which is the stent would be completely absorbed and there would be no residue left within the artery. So these have been taken off, but there are few companies, especially there's one Indian company who is coming up with a newer version of that stent as well. So we are waiting for the results of that. Interesting question. No, it's not a financial condition. In fact, more than 95% of the patient do get drug-eluting stent because there's a considerable added advantage and long-term benefit of a drug-eluting stent compared to bare metal stent. We would still use a bare metal stent, a very small subset of patients, especially who are at an increased risk of bleeding. For example, once we put a drug-eluting stent, we have to give them blood-thinning medications at least for a few months or at least for 12 months. But if the patient has an increased bleeding risk, he's awaiting a surgery within a month or 2, then we deploy a bare metal stent so that blood thinning medications can be stopped quicker or earlier in a bare metal stent compared to drug eluting stent.